Good morning, everybody. Okay, my name is Miguel Melendez. I'm a longtime volunteer with ThyCa, and I'm a caregiver to my wife for survivor for over 20 years. And welcome to this session. Okay, um, today is Dr. Dhillon. It will be doing presentation, and she's an endocrine surgeon and assistant professor of otolaryngology at Johns Hopkins Medicine of Bethesda, Maryland. Dr. Dhillon earned her medical degree from Keck School of Medicine of the University of Southern California. She completed a residency in otolaryngology at Los Angeles County and University of Southern California Medical Center. Dr. Dhillon has an expertise in endocrine surgery, laryngology, otolaryngology, parathyroid diseases and surgery, swallowing disorders, and thyroid diseases and surgery. She is currently researching the role of voice outcomes in patients after thyroid and parathyroid surgery when there is concern for vocal folds, weakness, or paralysis. So, welcome. Thank you, Dr. Dhillon.
Thank you, Miguel. Thank you very much for the intro. I want to say good morning, first of all, to everyone. And also just want everyone to know that this is a very informal talk on my behalf. I have a few slides prepared, but I want to spend the majority of time hearing from those that are on the talk in terms of feedback. So I'm going to reserve some questions of my own towards the end of the discussion. And if there's anything that comes up for the Q&A, please submit and we'll go over that because we should have plenty of time to address any questions you guys have. I'm going to share my slides real quick. Okay, so I hope everyone can see that. But today's panel discussion is really on improving communication between physicians and thyroid cancer patients. I want to focus the talk beyond just how to better communicate or what are the ideal ways of communicating that participants here have found with their own either endocrinologists, primary care, surgeons, in terms of their thyroid cancer care, but I want to focus a little bit on a decision aid. And I'll kind of go over what that means, because this is something that at least from the medical side and on a larger context is something we're really talking about in terms of improving quality of care for different types of treatments across the board. And again, I'd like to hear everyone's feedback on this as well at the end of the talk. So the objective today is to talk about patient-centered care. This is an important topic that's been around for a while, but I think has more recently, probably in the past decade, and even more recently in the past few years, taken into effect in terms of publications and people actually studying this and trying to improve what we'd like to call patient-centered care. But I'd like to talk about it in relationship to thyroid cancer treatment. I want to receive, obviously, your guys' feedback to help myself, as well as generally endocrine providers create a patient decision aid to help focus patient care. And then to discover what's important for what your quality of life was before, during, and after thyroid cancer treatment, and what you've heard of others that have gone through the process. So in terms of a decision-making aid, it's, like I mentioned, been a discussion for a very long time, but the emergence of clinical practice guidelines, and I'm sure all of you are very aware of this because this is hand in hand with ThyCa, but the American Thyroid Association, the American Association of Clinical Endocrinologists, the European and the British Thyroid Association, these are all large organizations of providers that provide care for thyroid patients and specifically thyroid cancer patients who in the past decade have really tried to develop clinical practice guidelines. And that spans across treatment of anything from hypothyroidism to medullary thyroid cancer to papillary thyroid cancer to thyroid nodules. And so the goal of these clinical practice guidelines has been to standardize care. And while guidelines are meant to serve as merely that, guidelines, and individual patient care is really individualized still between the patient and their physician, these guidelines are meant to help provide the best, most updated evidence-based medicine in terms of why we suggest and recommend with either, low confidence or high confidence a certain type of care. But however, this doesn't necessarily address patient-centered care, and it's different than clinical guidelines. Patient-centered care is really focusing on what the effect is in terms of providing a recommendation for a patient and how the patient either accepts that recommendation and their feedback. So really specifically, this involves the patient more than what we've already provided, which are, again, practice guidelines. So in 2001, the International Organization of Medicine listed patient-centered care as one of the 6 objectives to improve within this century. And the Patient Protection and Affordable Care Act created the PCORI, or the Patient-Centered Outcomes Research Institute. So this is an actual institute funded by the federal government that is meant to allow funding for research to look into patient-centered care in terms of outcomes and how to develop outcomes for providing more data, let's say, for how to provide what care patients really want. Right now, there's still work being done, and so there's no standard definition of patient-centered care. There's not something I can sort of outline in a sentence or two to define it, because it's still being defined. And while that may be still unfortunate, I think it's also something to be optimistic about, because that's sort of what we're actively trying to achieve in terms of thyroid cancer care. We're trying to develop a decision aid where we can still receive active feedback from either survivors, patients going through the process, or patients that haven't started the process, in order to better delineate what we need to do in order to provide the best outcomes for those patients on a more individual level. So there has been some literature review, which I'm going to briefly go over, and they have mixed results, that should say, with respect to outcomes. But the ultimate goal is to improve patient satisfaction and self-management. Few studies that have been done early on show that patients that are involved in their own care, so this is the care that affects them directly, beyond just guidelines, they feel the following things. They're more knowledgeable, they're better informed, they're less passive in their care, they're more clear about their values and how their decisions align with these values. So that takes a very personal approach to the patient making a decision about what they want from their care. There's less decisional conflict, less regret, and then there's a more realistic expectation of treatment. There's also, I should have mentioned as well, there's better compliance, meaning there's better follow-up with the patient and their provider or providers, so that there's less turnover and less dissatisfaction in care, such that patients seek care beyond their initial network of providers if we implement this. So, and this is a very busy slide, but patient decision aids basically allow the patient to become active in the decision-making process. So what does it require? What does a decision aid require for that to happen? So it requires that the information and all the options including the risks, benefits, and alternatives, be outlined very clearly. And I'll kind of go over how they're outlined, but they're outlined not just in a verbal conversation, but in the follow-up conversations, whether it be on paper, whether it be in a pamphlet, whether it be online, whether it be a module that the patient is able to review themselves. But it allows the patient to clarify their personal values and help them inform better decision-making. And it also allows the patient to adjust their decision. If the decision is made initially for one type of treatment, but upon review of these decision aids, it can change, that flexibility needs to happen. So that requires also the provider, allowing for that flexibility to happen. And so it can also require further follow-up appointments with the provider, whether it be at the beginning of treatment, during the treatment, or after treatment, in terms of how, you know, we need to change the outcome that the patient may seek. It necessitates more than one reasonable treatment option. So, you know, in terms of survival or risk of recurrence, especially in regards to cancer, you know, we know that there are certain treatment options that are better than others. But if it's beyond that, meaning, you know, if I'm able to have a better voice outcome, for example, or if I'm able to not have the morbidity of a neck dissection, and what would that mean if I opt for something else or opt to have radioactive iodine now versus later? These are all things we need to discuss in terms of quality of life outcomes. Ultimately, these decision aids do not replace counseling with the physician. So the goal is that these aids are to help. So in terms of before consultation, being prepared as a patient of what to ask, what to expect, what to think about, and then use during and after the consultation. So like I mentioned, it provides an ability to change the decision-making process, adjust it, modify it. And that also requires the provider, the physician, to allow for that to happen as well. So while it may ask more of the patient, it also asks, I think, just as much of the provider during, if we have these decision aids. So as I mentioned before, how do these aids exist? Various formats exist in the form of printed formats, videos, web-based programs. And these are all things that can be reviewed multiple times by the patient and the provider, and by the patient, and it allows the patient then to kind of consider their decisions more than just at the consultation they have with their doctor or doctors. The current following patient decision aids have been described or started, I should say. So there's a lot on, you know, breast cancer screening, prostate cancer screening, prenatal testing. The most relevant one for thyroid cancer patients that we have developed thus far, and it's still in the process of being reviewed longitudinally. So there's still long-term follow-up being analyzed, is on radioactive iodine treatment. So we don't have one currentry for surgical decision making, which is something of interest personally to me and a few others that work hand in hand with ThyCa. Our goal is to hopefully develop something in the next couple of years that'll be more surgical directed in terms of providing the best patient decision aid for surgery specifically, and the recommendations for surgery around thyroid cancer. But there is currently one that was published in 2010 and most recently in 2015 was analyzed. I think they're going to have another follow-up study, and I'm going to go over that one for radioactive iodine. Before I do that, I just want to show everyone a few examples of what I mentioned before as clinical practice guidelines from the American Thyroid Association specifically. This is the guidelines that most endocrinologists, primary care, obviously endocrine surgeons that are very up to date in terms of working hand in hand with ThyCa and the ATA. But this is the 2015 guidelines on management of thyroid nodules. And I just want to show everyone sort of the basis of what we use based on literature that we've reviewed as decision-making aids for the provider, not for the patient, but for the provider, and providing the best recommendation. So I'm not sure if anyone's familiar with reviewing the 2015 guidelines. They're on the ATA website, and it's a very large paper. But this is an example of the thyroid nodule algorithm from those recommendations in terms of, as providers, when we work up a thyroid nodule, how do we sort of get to the discussion of management? So it's a very busy slide, but you know, if there's a thyroid nodule, we proceed with evaluation with a neck ultrasound, and then depending on the characteristics of that ultrasound, a fine needle aspiration. Ultimately, it leads us to a classification system, which is another clinical practice guideline that was developed, the Bethesda classification, which then puts us into different categories and allows us to hopefully have a frank conversation with our patients about, well, if it's benign, if it's sort of in the in-between zone or malignant, what the next steps are in terms of management. So this is the Bethesda classification system. It was most recently updated in 2017. So this basically allows us, after we receive, this standardizes, I should say, the way that thyroid nodules are reviewed under a microscope. So all pathologists should be using the Bethesda classification system as the most recent evidence-based way of giving a diagnosis for a thyroid nodule, and at which point we then, as either endocrinologists or surgeons, have a discussion with our patients about the risk for malignancy in that nodule and what the next steps should be. So this is, again, most recently been updated in 2017. The most recent update incorporated a change to this diagnostic, in terms of the diagnostic category. Under follicular neoplasm or suspicious for follicular neoplasm, there's a new category, subcategory, where we're thinking that not all follicular neoplasms under a microscope are cancerous or concern for cancer. There's actually a category of a non-invasive follicular neoplasm or NIFP that was recently discovered that is actually pretty benign in behavior. So our treatment strategy for that category, when we see that, is not always as aggressive in terms of surgical management. But this is something, again, that we've recently updated based on this finding. One other thing in terms of guideline management, there's a new sort of, I wouldn't say new, maybe in the past 5-7 years, there's been new research and very good longitudinal data, follow-up data from Asia, Japan, and Korea that's been looking at the role of surveying very small papillary thyroid cancers. So again, according to our guidelines, if there's a diagnosis under a microscope for primary thyroid malignancy, surgery is recommended very strongly. However, active surveillance may be an option. So again, these are for very low risk tumors, and that's sort of categorized in a different way in terms of size, how many nodules a patient may have that may be concerning for cancer. But if it's very low risk, and there may be contraindications potentially for surgery, active surveillance is actually something we may be able to do. And this is still being analyzed in the United States based on our patient population. But as I mentioned, in Japan and Korea, microcarcinomas, which are less than a centimeter, the mortality rate of for these patients, even with a papillary that small, is less than 1%. So the Japanese experience has been really good. And I think at the most recent ATA meeting, Dr. Ito and his colleagues discussed even their longitudinal data at this point, but they've shown that even if, this was an old study, but when they first looked at it, they had over, 1,500 patients. And so they were able to follow these patients with biopsy proven papillary, very small, for over 15 years. And they showed that tumor growth was very, very low. So in terms of following the nodule, it would not grow very much. Lymph node metastases and then clinical progression of disease did not happen. And so these patients were observed, and very few actually had to undergo surgery. And so this is actually very good news in a lot of ways, because now that we're seeing a lot of patients with these very small cancers or very low risk cancers, we're not always having to be as aggressive, again, as I mentioned as before. But again, this all falls in line with the clinical practice guidelines. If a patient that has a very small papillary comes in and wants surgery, it's still a very individual conversation. And so again, this is all based on practice guidelines, but not a patient decision aid. And so we really want to focus on that patient-centered care, because we really want the patient to have ultimate feedback in terms of what they would like, despite all the evidence that we may have, so that their care is very tailored and individualized And so this is something that we're trying to do. As I mentioned, the most recent one we have is on radioactive iodine. They looked at 74 patients and they talked, so they basically, this was a randomized control study. And so in 2010, they created a web-based patient decision aid for patients, and they randomized 74 patients into either receiving the decision aid or not. And they talked about in both sets of patients, well, this is the benefits, the risks, and the implications for radioactive iodine. And then patients who were randomized to the decision aid were able to review at their own pace this web-based decision aid on, again, the role of radioactive iodine in their treatment. And so they had 60 minutes to review it. And so the results were after, when they reviewed both groups, that when they surveyed them, that the patients that had the decision aid, they felt that they were more knowledgeable, they had less conflict. They also felt that their communication with their physician was much more improved. Ultimately, the rates of receiving radioactive iodine didn't change, meaning that when they looked across the board, it wasn't that the patients that received the decision aid all accepted radioactive iodine and the ones that didn't, let's say, didn't feel comfortable with it. But at the end of the day, they found that, you know, the physician recommendation, whoever that physician was, in both groups was the most important factor. So the end of the day, the patients that received the decision aids felt that they were part of the care. And it's important to keep in mind that individual preferences ultimately impact the decision. And so I think that that's something we have to further study, because it's not just a matter of, oh, I received this aid, I feel more comfortable and I can proceed with this care, with this, you know, with this treatment plan. It's that we still need to analyze that individual patient, their background, their context, you know, their diagnoses, where they're coming from, their support group, what's important for their quality of life. As I mentioned, things beyond the cancer diagnosis, like voice, swallow, taking thyroid hormone, what's that going to mean? So these are all factors that have not been looked at, that still need review. And again, our goal as surgeons, and I speak on behalf of the American Head and Neck Society, because that's the largest group that we have, and the American Thyroid Association in terms of surgical providers, we all want to know what that decision aid would be like for the individual patient from a surgical standpoint. This slide's a little hazy, but I just wanted to show this real quick before I ask the polling questions, because we're kind of at the end of the talk for my half. But this is a recent paper that was actually published in JAMA Oto in 2020. This was written by a few different providers at the University of Wisconsin, and they're from the Department of Surgery. And they basically tried to, they took a panel of patients and patient caregivers. They took a panel of medical providers and surgical providers, and they asked both groups, what is the most important questions that you think should be asked for patients with low risk thyroid cancer? So these are patients that don't have metastatic disease. They have, let's say, a nodule that has papillary or follicular on a fine needle aspiration, and they're not necessarily going to need, you know, an extensive aggressive treatment up front, but they have the ability to consider all the options. And so they sat both groups down and they asked them to come up with a set of questions that would be important to them after they reviewed the literature. And then they went back and then they asked them again to choose the most important questions. And at the end of this was the summary of what they would like to say as abbreviated questions from their prompt list things. I thought this was really interesting, this chart, because you look at the far right column and you look at the types of questions being asked. And this is something that for the participants on this panel, I'd like to get some feedback as well. But these are, I think, really good questions in terms of, you know, for example, the nature of disease. What type of question as a patient would you want to ask? So, for example, is the cancer only in my thyroid? What happens if the cancer spreads? And if you jump to follow-up, or I'm sorry, surgeon experience and cost, which is at the bottom on the right, how many of these surgeries have you done? Do you use a nerve monitor? What costs will be covered by insurance? These are questions that this group is now trying to put forth in terms of a helpful, not decision-making aid, but helpful prompts for their surgical department, so that when patients come in with thyroid cancer questions, these are things that they themselves can review and say, oh, that's a good question. That's something I may want to ask. And so this is something I think as a step forward may be really useful. Obviously, this has not been reviewed yet in terms of submitting it to patients and seeing what they, what they feel. This was two groups of people that they developed these questions. So I'm actually curious to see what the outcomes will be with this. But I think this is also something that is an important thing for patients to have as potentially things to consider that they may not, at least initially when they're going through the treatment. So that's the end of my talk. I think I have some polling questions. I think Miguel is going to, yeah, thank you. I have a few questions. There's 4 of them. They're yes, no. If those of you on the participant panel can review and submit, then I'd love to get your feedback on these 4 questions in terms of percentage. And then I'm happy to review these as well as some of the questions I'm seeing on the Q&A. So I'm going to give you guys about a minute just to complete. All right, I'll give it a few more seconds and then I'm going to just briefly summarize the results. I think it's interesting that we have 10 participants that have answered. So it's a low number, I understand, but it's just interesting the split. And it's not really that skewed one way or the other with any of these 4 questions. But in terms of the first question, feeling you had good communication with your providers during treatment, 7 out of 10 of you said yes, and 3 said no. And I know that's a very, now they're 11. So again, 73 said yes and 3 said no. So I think that it's hard. It's a very large question, right? Good communication with providers could be, well, which provider and what kind of communication are you asking about? Because something might have been good and something might have been bad. So it's a pretty broad statement, but I think if we were to ask anybody in a summary statement how they felt about communication and the answer was then that says something in terms of feeling like you had relatively good communication with those that were taking care of you. So I think that even though we're higher on the yeses, it's the fact that we still have 3 no's out of 11, it says a lot. Was there anything unexpected? Again, that's a very broad question, very vague, but broad. And the answer is really relatively split. So that means that, again, thyroid cancer, treatment planning is not a one step, one function, move on to the next. It's not a sequential thing. It requires ultimately from the get-go, a large conversation that gets broken down into parts. And there are, from a provider standpoint, they're different players in those parts. But if there was something unexpected in that, then it's either, something we all have to sit down and address in a sort of a larger fashion, because sometimes one provider may not be able to provide the answer, but it requires that sort of coming back to the larger picture conversation or communicating better between providers. So if that's all part of what was unexpected, that makes sense. But the fact that it's split means that also means we have work to do. And then do you feel you had an understanding of your treatment plan? So again, this is sort of the larger understanding of what we were trying to achieve for thyroid cancer care. And again, it's split. So, the answer is 5 out of 11 is no, you didn't feel like you had an understanding of your treatment. So For those 5, for number 3, if you feel comfortable addressing it in the Q&A, I'd be happy to take notes and hear what understanding was not addressed, whether it be on the onset or during or after. And for those who did say yes, what do you feel, or maybe who did you feel, or who being the larger who, maybe multiple people, did you feel you had the best understanding from of your care? Was the information you needed to know provided in the right way? And I think this is going to highlight the Q&A in terms of the patient decision aid. And I've already read one person's response about the potential con of a decision aid. And I do agree that that's considerably, that's the unfortunate potential that we may have if we have something replacing patient-physician communication. And I'm not suggesting that we do that. I'm actually suggesting that we have this as a way for patients to have more information beyond the physician, because sometimes who you see isn't always the best information alone. And it's also how the information is delivered. So if we're able to provide information beyond the provider such that that allows the patient to come back to that provider or another provider and say, hey, I reviewed all of this and it doesn't sound like I understood that at the beginning, or this doesn't sound like it was discussed at the beginning. We need to review this. It may force us to have larger time, make more time, I should say, or refer patients to places where we can afford that time to have larger conversations about the ultimate treatment plan. And I think ultimately that's also important because not every provider may be capable of having this conversation, but the aid allows the patient to decide what's best for them. And I think ultimately that's something we should give patients, is the choice to provide, to allow them to choose their care. And at least from a academic standpoint, because we're still working very hard on it at an academic level, we're trying our best at this point to create centers or multidisciplinary teams where our focus is to have the time, whether it be not one person, but multiple people, such that a patient in terms of care, providing care, is able to find the time to have that communication with their providers multiple times if necessary. So that's something I know at Hopkins we're really focused on, is a multidisciplinary team. And I know a lot of institutions are like that, and a lot of practices are like that in the community as well, but not everyone's the same. So I think this last question, the fact that it's even still split, and the majority of you, 7 out of 11 said that you didn't feel the information you had was provided in the right way, says that we need to work on this. So I am going to go through, let's see, these questions and address them as best as I can. I think I'm reading again from Jennifer here in terms of working on a nonprofit patient advocacy company in Rochester and collaborating. And so you're interested in doing a study. I would definitely take a look at this model, and I'm happy to get back to you. I think the team here has my contact information, so you can definitely get my email and we can discuss further, but this would be interesting. I think, like I said, I know at Hopkins, this is something we're interested in. I myself, amongst a few other American Head and Neck Society members, surgical members, are interested in creating a patient aid. So the more the merrier, because we obviously need patient feedback to do this. So this is not something that only physicians are going to do to create. So I'm happy to get back to you on that and work on this further, because we already have some ideas in place. And again, just perusing Jennifer's response in terms of the communication and the behaviors of potentially the provider in terms of having time and the ability to have very let's say, open conversations about risks, benefits, and alternatives of the whole treatment plan is something we need to work on. I think time and provider time, the patient time in the provider's office, the patient time on a telemedicine visit, the amount of time you have to have a follow-up visit before, let's say, your treatment starts, and whoever potentially the liaison is between you and the provider, whether that be a nurse, a PA, a physician's assistant. Those are things that we need to figure out, and that's not going to necessarily be standardized across the board, just based on resources and how practices are run. I know at an academic center, it's a little bit more of an incentive, just because the type of care is a little bit more focused on that multidisciplinary team. But even then, we have to find a better way to incorporate patient follow-up and patient communication, whether that be in a visit, a telemedicine, which is a big thing since the pandemic. So that's also very helpful. But also, even if you through your portal or through emails or through a phone call. And so I think that is something, these are all very small things in terms of what we need to handle in terms of how a patient feels, what they're going through, the side effects of a treatment, or post-op, what they might feel that we have to address better. So I think there's a question here, is there an initiative to train doctors to act as decision aids? The idea of a decision aid sounds like another bureaucratic hoop that could prevent direct communication with the practitioner. And I think in terms of training, I know that the American Thyroid Association and the American Head and Neck Society specifically are working on, let's just put it this way, working on courses and panels to address this. So I know it's in the works for the societies. But in terms of training to act as a decision aid, I think ultimately, wherever a patient receives care, the idea of patient-centered care is for the patient to be involved. So I think it's not just a matter of what information is provided to the patient, but what the input is from the patient themselves in terms of how to address their own sense of outcome and quality of life. And so it does require time, and time beyond just the initial consultation. It's the patient aid is not supposed to be a stand-in for a follow-up. Let's just put it that way. It's meant to act as a provisional information, whether it be packet or module, so that the patient has the ability to recommunicate in another follow-up visit with the provider. And that's at least what we're trying to achieve from a surgical decision aid. So again, I agree with you. This shouldn't be a go-between. It should be a supplement such that the patient can then have another conversation or conversations with their provider to determine what they want from their care after the initial consult.
Dr. Dhillon, I just wanted to add, I guess instead of, I think trying to think of the wording, it almost seems like it facilitates the patients to empower themselves by informing themselves, from a reliable source, as opposed to, just searching the web, all different sites in terms of trying to inform themselves. I think this almost seems like a more reliable source in terms of educating the patient before they visit the doctor.
Yeah. You're right. Thank you, Miguel. Yeah. So again, the aid, correct, is the information that we hope to put into an aid. And I think this is what the radioactive iodine study has done in terms of their web module is to provide evidence-based medicine to the patient beyond just clinical guidelines, which is something that I think is more directed toward the providers in terms of providing, this is the best evidence we have to suggest this treatment. Because that's a little bit more dense in terms of the research and the data. So our goal with an aid is to say, this is the data that we have in a sort of a most up-to-date fashion, such that a patient can review it. And if the patient agrees or disagrees with the aid, that's relevant. And so that can lead to further conversations. But you're right, the information is with evidence backed. And I think the one thing about patient decision aids that we don't have data on right now, like strong data from a surgical standpoint, is outcomes. So, if patients come to me and say, for example, how's my voice going to be after surgery? What's the data on it? It's actually pretty poor. And the counseling that we have available is limited to, well, these are the risks of a vocal cord weakness, or these are the risks of potentially having, hoarseness, for example, that can last so long. But if we were able to provide that in a patient decision aid, then patients could say, look, there's no data behind this that's strong, but this is something I should consider, because it may not even be a question for somebody before they're walking in the door. So I agree. I think beyond having evidence-based data to say these are the right questions to ask, such that I'm not Googling or looking things up and getting freaked out by what potentially be out there, but these are the more concerted questions I should ask. It should also allow patients to be like, oh, the data on this is not so good, but it's definitely something that my provider is allowing me to think about, such that I can come back and say, that's important to me, or that's not important to me in the long run. Because we as providers don't also know what's important to a patient until sometimes after all the treatments, like, well, that was really important to me and it didn't happen, or it did happen. So I think that allows that conversation to, take place early on. Someone here, there's a mention of monitoring. I guess this is nerve monitoring in 2009. Or monitoring of their lymph nodes. I'm not sure if it's one or the other. But I think ultimately the statement says that if someone is not eligible for this monitoring, it should still be discussed why that can't be, so the patient doesn't feel like they didn't get quality information. So I think, again, that's agreeable. That's completely understandable. And that's something we would hope that if this information is provided for patients, that conversations can happen without feeling like it's not going to happen, because the patient can at least say, well, I've reviewed this, I want to talk about this, so let's discuss and get the information they want from their provider. Christy here said she had a lobectomy due to a small single tumor. We found microscopic cancer in the tumor, learned that there's PTC in lymphatic system, but we do not know if it is a lymph node. She's low risk, but there was disease in the lymph nodes, concerned the ultrasound will not catch it timely. I would like to actively monitor, but have scheduled the additional surgery. The idea that I will do radioactive iodine sooner to catch. However, I catch the microscopic disease. However, I feel this is too aggressive. How might I choose? Do you have a decision tool for this scenario? So this is a very specific question in terms of care. I would tell you that if you feel that you are being pulled to do one certain treatment because you're not quite sure the risk of there potentially being lymph node metastases, that is not detectable on the ultrasound, but there was concern on the pathology, then I would say that it's probably the two options at this time is either to repeat the ultrasound. So if there's not anything detectable, but you're potentially going to undergo surgery for something that is microscopic, it's important to make sure maybe a second time with another ultrasound at another institution or another place to be sure we're not dealing with not just microscopic disease. The second thing I would tell you is if the decision has been between you and an endocrinologist or a surgeon to undergo surgery for something that's not detectable, that the data right now shows that if it's not detectable, then you don't need to undergo prophylactic lymph node surgery. A second opinion is probably warranted at an academic institution. Just because with this very personal information, I'm not quite sure what the actual testing is showing, but it's important to get a second opinion before undergoing another surgery that you may or may not need. So I think from a decision-making aid, this would all be outlined in that, but also the American Thyroid Association clinical guidelines have already discussed this in terms of the need for further surgery for lymph node metastases. So again, I would seek a second opinion at an academic place. If you're going to undergo potential further treatment for something that's you're not quite certain is going to change overall survival or risk for recurrence, because any further surgical management, if it's not 100% necessary, you don't want to undergo those risks. Okay, I have a note from Alyssa. I did not complete the poll as I'm a parent of a young adult and not the patient. I do feel that a decision aid would be helpful. I need more information than the doctors provide, but my child does not know what to ask or may possibly want to know, would be able to make that decision. So if you're a caregiver of a patient undergoing thyroid cancer treatment, then again, I appreciate the comment. I think a decision aid would help not only the patient, but the provider be more part of the patient's journey. And that can be a family member of a child. It could be, a partner of someone going through it. It could be a friend. But our hope is that this information is something that that patient can share, so that, again, more information to their support team is the better, so that they can make, again, these are all part of the decision-making process for any person. And if someone needs that support team to help them with that process, then our goal is to have that aid relevant for those people as well. Penny writes, I went into surgery thinking I would definitely have radioactive iodine. I was over 55 and my tumor was expected to be over 1.8, I believe maybe centimeters. The surgery showed it was 1.4 and multifocal, had positive margins. My surgeon said they were microscopic, so I did not have to undergo radioactive iodine. I was a candidate to not have radioactive iodine. So I spent the weeks between surgery and meeting with my endo, researching and stressing. My TG then went up to 1, my endo 70 for radioactive iodine. But when I met with the radiologist, he spent 45 minutes talking me out of it. Yeah, so again, our hope is with this aid to allow patients to review the information and again, hopefully have some more data behind their decision process in terms of if there's some conflict or back and forth, I should say, between opinions, which is not uncommon, unfortunately. I think the other thing that we're hoping with this decision aid is to have patients understand that if that is to happen, there are places in the United States, institutions that have a multidisciplinary team. So some of that conflict can be a little bit more not negotiated, but discussed frankly in like a tumor conference or a meeting of those providers, such that the patient's care plan is sort of overall discussed, and then the patient is involved with that in terms of all the providers being there at the table at the same time.
Dr. Dhillon, I wanted to go back to Alyssa. Although the caregiver and the parent are the decision maker, being that it's a young adult, although they're not capable of making decisions on their own, but they should be part of the decision in terms of at least being informed. I think, as a caregiver myself, I would imagine that would be a role.
Yeah, no, agreed, 100%. I think, our goal is to make it a decision aid for the patient, whoever that patient is, but, quality of life for patients is also is influenced, right? Not just quality of life, but treatment planning is influenced by the support team that person may have. And whether or not that, support person or people are involved 100%, or it's just, for example, a young adult or even an older adult. I think like if they're the ultimate ones to make the decision, everyone on board with that person should feel like they understand the care going forward, rather than sort of being at the sort of the periphery of that plan.
So I believe you have about 5 minutes left.
Thank you. Yeah, I was just going to answer these last two. one from Jennifer, and then Raphael has a comment here, which I'll address. Again, I appreciate the frankness of these comments, because this is very important. And I'm glad we're having this conversation, because these are all very important for me to take back to our group at the American Head and Neck Society, because our goal, as I said, is to start implementing some of these feedback sessions into our own decision aid planning. But Jennifer wrote, answer how professional patient advocates can assist doctors in distributing knowledge and understanding. Can professional advocates help bridge that gap? The answer is yes. In the world of HIPAA, we have to be a little mindful. Obviously, we have patient support groups. We're lucky at Hopkins to have patient support groups within our cancer teams. I always refer my thyroid cancer patients to ThyCa, and with Gary's help, I've had a few people that locally that are willing to meet with patients, but we have to be HIPAA compliant, such that some patients don't want to have their information shared. But if we were able to provide something where we have advocates, even on a national level, again, telemedicine is making things a lot easier. I think it would be a great asset for this, because I think that conversation and the support network that someone can find with speaking to another advocate is very useful. So that's definitely information that we at the American Head and Neck Society want to implement. We just have to be careful of the sharing of medical information beyond the patient physician. And so there probably will require some consent process for that to happen, but I don't foresee that as a barrier. I think that that's definitely something we can definitely do as part of our decision aid process. And then Raphael, just to end the question here, the question Q&A session, mentions here that thank you, the patient decision aids would have been helpful to me. I was ill with fibromyalgia when I was diagnosed with thyroid cancer, and my ability to process all the information from my endocrinologist and surgeon and advocate for myself was limited. And I am sorry for that. There's more than sometimes just thyroid cancer going on. And this is important. Again, Raphael's own medical history is important in terms of dealing with this diagnosis and processing, but also going through the treatment. My surgeon discussed more information specific about my case and gave me statistics in a positive outcome scenario for me. I hope that the treatment plan went well for you and your surgeon, if he was your director of treatment, if he was your go-to, that's great. I think ultimately this is something that we all have to keep in mind, right? It's not just the other medical issues that a patient may be going through, but that's super important. But also the fact that, where are they coming from? Like, where is a patient coming from when they get diagnosed with thyroid cancer? What is their own personal history? What is important to them? What is their, unique social situation, their financial situation? What's going to influence, for me, I will tell you from a voice standpoint, if a patient is someone that needs their voice for something, I have to be very honest about the recovery sometimes from just, having surgery, and what are the risks of having a vocal cord weakness if you're a pastor, if you're a lecturer, if you're a professor, because these are, even though it may not end up being a vocal cord weakness, your voice can still be affected, and for how long. So these are all things that we have to really break down in terms of where a patient's coming from, what's important, and how are they going to process this if something else is going on in their lives. And I think that is something we have to not just side note in a decision aid, but also be upfront about. I want to thank everyone. And again, I appreciate all this feedback. I know that my information is going to be provided in terms of email, so feel free to send me an email, and I'm happy to get back to you about any of this. And again, hopefully by next meeting, we have some more data from at least the HNS on a surgical decision aid. So that's our hope in the next year. Thank you.
Thank you, Dr. Dhillon. The session was totally informative. I think a lot of people gained something out of it. And, thank you for your time in terms of answering every single question. So hopefully, this study will go someplace, to benefit the patients. Thank you.
That's our hope. Thank you.
Okay.
Thank you, everyone.